Respected chairperson, dear friends, very good morning to all of you. I'll be talking to you on regarding clinical presentations, how they have changed since the COVID-19 era. During the COVID-19, we followed the advice where most of the immunosuppressions were have restricted use. We were not going up with iron immunosuppression, resulting in flare-up of uveitis. What we have seen is following COVID, we have seen varied manifestations. In addition to reactivation of uveitis, there were vascular occlusions. In our study, we found that in addition to the routine laboratory investigations, we also noticed increased D-dimer, serum ferritin, LDH, and raised inflammatory markers such as ESR and CRP. In this, serum D-dimer and ferritin levels were significantly elevated patients with vision-threatening ocular manifestations. In addition to that, we also have varied ocular manifestations following COVID-19 vaccination, varies from anterior to panuveitis. In our cohort, herpetic uveitis was the commonest among the infectious uveitis. The reactivation of HLA-B27 among the non-infectious uveitis. We'll see case examples. Here is a 14-year-old girl, known case of bilateral intermediate uveitis. She had inadequate response with systemic immunosuppressive therapy with MMF or methotrexate and tacrolimus. All these drugs did not work well. Finally, we have to shift her to a biologics injection adalimumab with methotrexate, following which she started showing resolving inflammation. By then, the pandemic hit. So this is a picture where we could see the resolving inflammation. Patient lost for follow-up for 4 months due to the pandemic. She presented with flare-up of inflammation. So adalimumab dose was increased to 40 milligram once in 2 weeks. We started noticing resolving inflammation. Subsequently, the patient had fever suspected to have a COVID-19 infection, following which systemic immunosuppressive therapy adalimumab was stopped. And subsequently, when she came for follow-up, there was flare-up of inflammation. Then we restarted the adalimumab. However, we did not find adequate response with injection adalimumab following COVID. So we shifted this child to tafasitamab JAK kinase inhibitor. Started responding to treatment. Then the child developed superadded skin fungal infection. At this time, we could see the flare-up of ocular inflammation with change in the morphology of snowball opacities. We added systemic antifungal with continuation of anti-inflammatory therapy, following which we could see the resolving inflammation with changing in the morphology of the snowball opacity. The story does not end. After 2 months, the child goes and takes the COVID vaccination in the school, and following which there was mild flare-up of inflammation. We topped up with systemic steroids. The inflammation started responding. Now the child is doing well. So here, this is a immune-mediated uveitis, had a flare-up of inflammation following COVID, and subsequently have to put on JAK kinase inhibitors with superadded fungal infection. Again, the child had vaccine flare-up. So changing morphology from non-infectious to superadded infective infections with vaccine flare-up in this case. Next, we'll see the second case. It's a 19-year-old lady, a known case of JAA on methotrexate, presented with chronic anterior uveitis, and also she had subclinical retinal vasculitis with macular edema. Her inflammation resolved after adding injection adalimumab along with methotrexate. She was inflammation-free for 6 months. Then she took COVID vaccine. She took vaccine. Complaints of new floaters in both eyes. The floaters developed first dose in one eye, and then it started seeing it in the other eye as well, supposed to be the normal eye. FFA showed diffuse perivascular leak in both eyes, right eye more than the left eye. Superadded infective etiology was ruled out. We treated with topical difluroprednate with continuation of injection adalimumab with methotrexate. Subsequently, the inflammation was resolving, and finally it settled down with this treatment. The next case is a 56-year-old lady, known case of rheumatoid arthritis on methotrexate, Presented with pain, redness, and blurring of vision, she developed herpes zoster ophthalmicus 6 weeks following Covishield vaccination. Initially, she had fever after the vaccination that was managed with antipyretics. 6 weeks later, herpes zoster ophthalmicus with viral anterior uveitis responded well to topical and systemic antiviral therapy along with topical steroids. So we have seen most of viral herpes zoster following COVID vaccination in our patient. The next 20-year male known case of Behçet's disease with retinal vasculitis on treatment with azathioprine 150 mg per day. He was treated with oral azathioprine, entered remission, maintained the regular immunosuppressive therapy during the pandemic, and he had an uneventful course with no relapse in spite of receiving COVID vaccination. The next case is a 29-year-old lady, chronic VKH, had resolving inflammation. She's on azathioprine, cyclosporine, and prednisolone in the pre-pandemic period. So this is a picture of a fundus. She lost for follow-up, presented with flare-up of inflammation. She was treated with top-up of increasing the dose of systemic steroids with continuation of systemic immunosuppressive therapy. She lost again for follow-up for 8 months due to her pregnancy. She stopped all the medications on her own because of her pregnancy and presented with flare-up of inflammation with worsening of visual acuity. Subsequently, this was controlled with additional systemic steroids and immunosuppressive therapy was restarted. In spite of immunosuppressive therapy, there was persistence of inflammations in her. On top, she took the Covishield vaccination. She had flare-up of inflammation. This is a post-vaccination. We could see the presence of iris nodules and responded to systemic steroid therapy. Adalimumab was added in addition to the azathioprine and cyclosporine. In spite of adalimumab, she had persistence of inflammation. Finally, we have to start on injection golimumab monthly once dose, and subsequently she responded well to the treatment. So the next case is a 73-year-old lady presented with pan-uveitis, probably of sarcoidosis, responding to methotrexate. She had angle closure for which she underwent YAG peripheral iridotomy, and she had a macular edema for which topical difluroprednate was given to her. Patient last for follow-up for 13 months due to the pandemic. She was in the village. She stopped all the systemic immunosuppressive therapy. Flare-up on and off, she started using difluroprednate on her own. Subsequently, she presented with increase in intraocular pressure and optic nerve damage in the right eye. These are the challenges we faced because they were not able to continue the systemic immunosuppressive therapy. Self-medication resulted in secondary complications following uveitis. Necessity is a mother of all improvisation. If we ask pre-pandemic, we say teleconsultation uveitis is no. But in COVID lockdown time, teleconsultation, with that we have a viable options, monitor the treatment or continue the treatment in chronic uveitic cases. To conclude, non-infective uveitis with flare-up of inflammation with aggressive course was seen following COVID and also following COVID-19 vaccination. We had lot of superadded infections, both viral and fungal following COVID infection. And we also had vaccine-triggered inflammation with varied manifestations, but most of them responded well to topical or systemic corticosteroids therapy. Teleconsultation played a role in monitoring the response to treatment during lockdown period in COVID-19 infection. I would like to acknowledge the team members. Thank you for your attention. I take this opportunity to invite you all for UCCon 2023. This is going to be in Abu Dhabi with lot of academic feast and also sightseeing. So exciting program is awaited for all of you. We look forward to seeing you in Abu Dhabi. Thank you for your attention.